Thank you very much for the kind invitation. I will probably need a few of your neurons to help me solve a couple of mystery cases. Just before that, in our hospital, as Dr. Sagris said today, we have the usual suspects of stroke, the usual stroke mechanisms. But as you can see on the bottom on the left, the rare causes of stroke also come up to 5 to 6% of all strokes. So that's in the overall cake of stroke mechanisms, about 5% are rare causes of stroke, so 1 in 20. Now, however, if you look at younger patients below 50 or 55 years of age, you can see that this doubles actually. So in younger patients, you have about 10 to 12% of patients who have rare causes of stroke. So when should we suspect rare causes of stroke? So one would be maybe in younger patients, but the other one would of course be unexplained stroke, ESUS and others, especially if there are very few risk factors, that is including younger patients. Or you have also unexplained stroke and recurrent strokes. Or maybe you would have multifocal stroke, again without an evident cause. A couple of other hints would be if you have at the same time ischemic and hemorrhagic stroke. This could be things like vasculitis or endocarditis, presence of a systemic disease, so somebody who is known to have, for example, HIV or rheumatological disease or cancer, he may have a rare cause of stroke. And finally, of course, history of family disease, vascular family disease would be a good hint as well. So this should help you to think of a patient to have maybe a rare cause of stroke. Now, does it really matter whether the patient has a rare cause of stroke? And we have just published this paper with the 222 patients with rare causes of stroke. And as you can see, it does matter a lot. So patients who have a rare cause of stroke compared to all the others, they have about 2 times worse outcome over 3 months, and mortality is doubled, not doubled, but maybe 50% higher, and stroke recurrence is higher as well. And the reasons for that are probably 2. One is that, well, of course, rare causes of strokes are often associated with other diseases, again, like cancer or immunological disease, but also these are rare causes, so we don't know very well how to treat them, so they have a worse prognosis. So this is the checklist we will go through in the next 20 or 25 minutes, again looking for the pearls among our patients. And the frequency of these 9 or 10 categories in our hospital are the following. Again, a cake, you can see the most frequent ones are therapeutic and diagnostic iatrogenic interventions, patients with oncological disease. Vasculitis is quite rare, actually, only 7%, but then other vasculopathies at the bottom, the green one, is again quite big, and rare cardiac causes like endocarditis, tumors in the heart, and things like that. And as you can also see, genetic causes are on the left side. True genetic causes are extremely rare among the rare causes of stroke. So very interesting, but not frequent. So here you have to help me, a young lady who used to be or is in good health, but since 1 month she doesn't feel well, her vision is a bit strange, she has a bit of diplopia, instability, doesn't concentrate as well as she usually does, a bit of headache, has a hearing problem on the left, which is also new. And I think we did an MRI and we could see these funny white spots, mostly in the corpus callosum and a little bit in the cerebellum as well. Any suggestions for her etiology of her funny stroke-like symptoms and lesions? Anybody? Varicella? Good point. Something inflammatory. Any other type of vasculitis maybe? Young ladies, looks a little bit like multiple sclerosis. Vasculitis from SUS? Takayasu, very good. Could be as well, but these are more large vessels. So the small vessels would be what we call the Susak syndrome. Susak, have you heard of it maybe once or twice? Good, so we also call these lesions in the corpus callosum snowballs, like white snowballs. You can see round lesions. Of course, you think of multiple sclerosis, and that's a little bit the problem. They also have vasculitis in the retina, and they have hearing problems, gait problems, cognitive problems. So it can actually mimic both clinically and radiological multiple sclerosis. So we have to be very careful. But it's treatable. Many times it's actually curable after a year or so of immunotherapy. So if we talk about vasculitis and stroke, you can categorize them in three large categories, either a primary systemic vasculitis like lupus or other things that would also affect the brain and cause strokes, or systemic vasculitis associated with other disease, or then just a single organ vasculitis isolated of the brain. Just one other case here. So this is an elderly lady with multiple strokes, as you can see, in multiple sites of different age. And this is a typical presentation with cognitive symptoms often of primary CNS vasculitis. The problem here, it's really very difficult and a very rare diagnosis. And there is actually not really a gold standard. We always think biopsy is the gold standard. The meningeal or brain biopsy would diagnose the vasculitis, but in fact can even be negative in 20% of cases. So often this is a kind of a diagnosis because you have ruled out many other things, and maybe even your brain biopsy will be negative. And one last inflammatory thing would then be infectious vasculitis, like George, who mentioned VZV vasculitis. Other viruses can cause it as well, herpes, Zika, and other bacterial infections. For example, hepatitis with cryoglobulinemia and hypercoagulable state. Now, one, of course, that you've heard of is COVID-related stroke. And as you probably know, in fact, yes, if you do have COVID, your risk of having cerebrovascular disease is increased. It's about a twofold risk to have ischemic stroke, and it's about a sevenfold risk to have venous thrombosis in the brain or hemorrhagic stroke. So yes, COVID is a risk factor for stroke. And Dr. Dimitris has written a nice review article here about all the different mechanisms in terms of endotheliopathy, hypercoagulable states, cytokines, and all these things, how it causes a stroke in patients with COVID. And we've also been having a chance to work with Professor Dayos on a worldwide level with the global stroke registry and COVID, and we could show with him that actually COVID patients with strokes are more severe, have a worse prognosis, and also have a higher hemorrhage risk if we thrombolize and thrombectomize them. Now here would be another one that's a very difficult one, but I'll show it anyway. A young man, he has smoking, cholesterol, and a PFO. So the right MCA stroke we thought was due to these factors, including PFO, so we closed the PFO. But unfortunately, he came back a couple of years later, like 2 years later, and he had another right MCA stroke. And all the vessels were fine, there was no dissection and no nothing. So we were looking for rare causes of recurrent stroke. So given that the vessels were normal, we had to look elsewhere. The heart looked normal as well, the PFO was closed. Any suggestions, any thoughts that come to mind, especially maybe on a hematological side or prothrombotic? What would you think of in terms of prothrombotic states in a young patient? Anybody, maybe antiphospholipid syndrome should be considered. Anything else? Cancer, but it's less likely because it's like 2 or 3 years later, so there was no cancer over 2 or 3 years. Anything else? Okay, good point. Any metabolic disease, maybe? So, very good point. Yeah, that's a good one too. Good. So we did the whole workup also for hematological disease, and at the end we found hyperhomocystinemia in this patient. As you know, there are two forms, the genetic one, which is quite severe actually, with venous and arterial thrombosis, and then the one with nutritional or malabsorption, which is more treatable. So this patient had a genetic form which is less treatable. We still give them vitamin B complex, but this works better in the nutritional form, and it doesn't work very well in the genetic form. Now, in terms of hypercoagulation, we've already heard a talk this morning about this problem. There are many different forms of hypercoagulable or prothrombotic states, including hematological, neoplastic, and perineoplastic. So let's look at a few of them. Well, the first one is always the big discussion: should we look for factor 5 Leiden? Should we look for protein C, protein S? And really, I would warn you a little bit about that, because the large analysis showed that in adults there's virtually no correlation of these coagulation factors with stroke. There is a reasonable correlation with venous strokes, but not with arterial strokes. And the problem is that if you do look for these things and you find one of these things like factor 5 Leiden, then the risk is that you overtreat patients. You start to give them anticoagulation and things like that, which doesn't work on the arterial side, even for these patients. So again, we nearly never do prothrombotic workup in our patients, not even in PFO usually, because, as you know, the trials for PFO, they all came to the same conclusions, that as long as you have a rope score which is high and a very bad-looking PFO, then you have enough arguments to close the PFO where you don't need further testing. So maybe in a borderline situation, but even there, we're not sure about that. A couple of hematological causes on the erythrocyte side. So there is a patient with sickle cell disease. That's the one you mentioned, paroxysmal nocturnal hemoglobinuria, microangiopathies, and myeloproliferative neoplasms. Many of them have known genetic mutations. And then as we talk about procoagulant states, you have to talk about cancer. So yes, they have increased risk for everything: venous, arterial, ischemic, and hemorrhagic strokes. And there are a lot of different mechanisms. As you know, the most frequent one is probably simply proteins in the blood, circulating proteins, prothrombotic states. But you can also get dehydration, chemotherapy that causes strokes, and radiation. We've just had this paper accepted. We worked on it together with Professor Milionis for the last couple of years. And what we found in our population is that in about 6,000 patients, 17% had stroke at some point in their life, but most of them actually had it in the past. The 11% had it in the past, and only 6% have active cancer at the time of stroke. And these 6%, most of them are known at the time of stroke, but a few of them you would only diagnose as the stroke occurs or in the next few months. And most frequently, these are intestinal cancers and lung cancers that are associated with prothrombotic states and ischemic strokes. Now, 2 or 3 short checklists. Drug-related strokes, again, it's often chemotherapy, as we've mentioned. Of course, hormones, estrogens are prothrombotic, and a few other ones, including immunoglobulins. Also, of course, street drugs can cause ischemic and hemorrhagic stroke. You all know that. How about the problem of migraine and stroke? Well, there are several mechanisms, as you know, and to really diagnose what we call a migrainous stroke is quite strict. So the criteria by the International Headache Society are that the aura that the patient has is the same as usual, that you have to have mandatorily an acute ischemic lesion on imaging, and that you have excluded all other causes. So true migrainous infarction is actually very rare. However, migraine is by itself also a risk factor for stroke, and the PFO may be a connection of that, which causes both migraines and stroke. And then there is a migraine variant, the Handel syndrome, which causes sometimes stroke-like symptoms. Another checklist would be then pregnancy and puerperium. So if you have a lady either during pregnancy, while giving birth, or immediately after, there's a long list. You really have to start your workup from zero and go through all the different possibilities, dissections, PFOs, heart disease, and so on. So it's really very heterogeneous and long, the list of potential causes of stroke or stroke-like symptoms in this situation. Now here's another quiz for us or for you. A lady who had some Hashimoto's in the past but was controlled. Now she has a TIA with aphasia and a right arm weakness. She had normal perfusion. She has a mildly elevated sedimentation rate. CRP is normal. Now these are her images, diffusion MRI. As you can see, there are multiple small strokes and one which is a little bit bigger in the middle there, which may be caused her aphasia and the right arm weakness. And these lesions are kind of disseminated over time and space. And in fact, if you have this picture, clinical or radiological, of lesions that are disseminated in time and space, ischemic ones, you have to think always of the three same categories. These were either vasculitis, cardiac sources, of course, or hypercoagulability. So we've already talked about hypercoagulability and vasculitis. So probably I will now talk about this, which is a myxoma. So this lady was not lucky. She had a myxoma in her atrium, which we resected, but luckily it was completely removed. It did not reoccur, and it was not malignant. As you know, it's rare that these are malignant. So this is a rare cause of cardiac stroke. Here is a short list. Fibroelastomas are also found occasionally or even intercardiac metastasis. And of course, endocarditis is a rare cause of cardiac emboli. Again, another story of a lady who had, again, recurrent minor embolic strokes, but maybe every 1 or 2 years, not as frequent as the other lady that we just seen. Recurrent epistaxis since she was a child, some dyspnea when she walks up the stairs, and then she has these, or should I not show the skin lesions maybe? Anybody knows what this could be? Any red flags? Let me show you the skin lesions maybe. Any suggestions? Little hemangiomas. Okay, I think some of you know what this could be. Let me show you also the chest X-ray on the left with these nodules, and then on the right you can see these little balls. They're the red balls that are connecting the red arteries with the blue veins. So these are pulmonary arteriovenous malformations. So the diagnosis, you probably know, would be Randy-Osler-Weber disease. And here, most often, the strokes are related to these right-left trends. So it's like a PFO, but the PFO is not on the heart side, but in the lungs. So there's paradoxical emboli going through these lesions in the lung. And if you do microbubble test, then you have to ask the cardiologist to wait longer than usual because it takes more time for the bubbles to get to the other side. These patients also get occasional gas emboli or brain abscesses. There are now a lot of mutations known for this genetic disease, and in fact, this is one of these genetic mid-size arteriopathies due to collagen disorders. There are many others, as you know, Randy-Osler, but then all the Ehlers-Danlos ones, fibromuscular dysplasia, neurofibromatosis, and things like that. And these patients, they all have weak walls in the vessels, as you know, mostly on the arterial side. That means they all can develop either dissections, aneurysms, dolichoectasia, but also aortic disease. So this is kind of an overlap of these collagen genetic diseases. Oh, here's one maybe you will recognize, 64 years old, history of migraine, acute gait instability, but no true Hemi syndrome or aphasia, but so it wasn't quite sure clinically whether it was stroke or not, but she had bilateral corticospinal signs when we examined her and quite a bit of cognitive problems. Any suggestion for this MRI? CADASIL, okay, very good. So it wasn't that difficult, was it? You know, CADASIL, it's part of the small vessel disease, and there is a whole range of those. Luckily, the others are even rarer than CADASIL, but there's a huge number of those, and many of those actually already present in childhood, but others, like CADASIL, would only become manifest in adult age. Now, don't forget, there are many causes, vascular causes of white matter disease or diffuse white matter disease. Here is a checklist. Well, we all know, of course, the chronic hypertensive leukoencephalopathy, but then cerebral amyloid angiopathy would be a white matter disease as well, mitochondrial, vasculitis, and so on. So keep this checklist in your pocket when you see kind of widespread lesions, especially in a patient who does not have many vascular risk factors. Again, need your help for this one. Quite young man, lacunar syndrome with a ataxic hemiparesis and a lacune. He has some anhidrosis of his feet and hand with some pain and then some skin changes. Any suggestions at this point with these little dots here, these little nodules in the skin, in the umbilicus? Any suggestion? What rare cause of stroke this could be? No. Amyloidosis, okay. Actually, amyloidosis is interesting because it very rarely causes both brain disease and disease elsewhere. It's kind of like two different worlds, but there are a few familial situations. Any other suggestion? Fabry's disease, very good. So this is Fabry's disease. As you know, a very internistic disease as well, with vasculopathy everywhere, renal failure, heart problems, and eye problems. Of course, the genetics are known, the treatment is known as well. It does work well, but of course, it's much too expensive. So this is a checklist if you have patients with stroke and skin disease. We've already seen Fabry disease. We have seen Ehlers-Danlos. We've seen Randu-Osler-Weber. Of course, there are some infections which can do with lupus and other genetic diseases. So we're making good progress. So this is a young physician who was sent to me, at least the slides, by a colleague, Professor Arsovska, and she had a TIA, a right hemispheric TIA with a right Horner syndrome. And then a year later or so, she had some pulsatile tinnitus in the other ear, in the left ear, and she got an MRI. And you can see the blue arrows. They show these carotids, which are kind of sausage-like carotids with both aneurysms and stenosis. Anybody would have any suggestion what disease that could be? Both carotid chronic disease. Fibromuscular dysplasia, very good, okay. That's a very good candidate. Now, interestingly here, I put you some red arrows as well. Where are the red arrows? Are they coming? Yeah, here you can see these red arrows on the right. Do you know what this is? This thing is the elongated styloid process that is touching actually the carotid arteries. And this syndrome has a name. Anybody knows it? If the styloid process goes and scratches the carotid on both sides and causes recurrent dissections. It was described by an ENT physician about 80 years ago, Dr. Eagle syndrome it's called. Okay, so it's a purely mechanical thing. It's not genetic, it's purely mechanical. If you're not lucky that your styloid processes go and scratch your carotids on both sides, then you will get chronic or repetitive dissections of your carotids. So it's a rare form of cause of dissections. And fibromuscular dysplasia is another one which causes also dissections. Very good. So here is a checklist of other vasculopathies which are not inflammatory. Maybe some of them are genetics, but we don't quite know. So I think we're coming to the end. I just have to mention quickly the Moya-Moya syndrome, also because of two things. One is that there was a recent update on the classification and of the diagnostic criteria by the Japanese, but also because if you have Moya-Moya-like symptoms and arteries in the brain which are occluded, you have to keep in mind that you have to exclude first many other diseases. And here at the bottom is a checklist of diseases that you have to look for, including lupus, antiphospholipid, and Sjögren and things like that, before you can say it's a true Moya-Moya syndrome, and then, a true Moya-Moya disease. And then some of them are now genetically proven with mutations, but not all of them. So this is the kind of workup you have to do first, exclude other causes that cause a syndrome, and then say maybe, or probably it is disease if you have the criteria, and then you can do genetics. So maybe one last case, 74-year-old, he has a biopsy of a lung nodule, and at the end of the procedure he gets syncope, some dysarthria, and gait ataxia. On the left you can see the MRI lesions, kind of little embolic strokes, and here is a CT of the heart, and anybody knows what these black dots are in the heart? What could that be? He just had a procedure going into the lungs, and then what can... Air bubbles, right. So actually he had air bubbles going from the lung, from the biopsy, into the heart and into the brain. So he had actually gas emboli, which you can see better on a CT. You can see the little black holes here as well on the CT. So another rare cause of strokes, iatrogenic, as part of a diagnostic procedure. And well, it's of course more frequent to have strokes from therapeutic interventions. If you do a carotid stenting or carotid operation, heart operations, and so on, it can cause stroke. But don't forget, even our diagnostic procedures occasionally can cause stroke, and we have actually published with Dr. Papavasileiou a couple of cases where during the carotid ultrasound, the plaque was mobilized and was sent up to the brain and caused strokes. So to finish, if I have a suspicion of a rare cause of stroke and it's not very obvious from the circumstances, how do I proceed? Well, I go stepwise from the point number one, which is I do my standard baseline workup like angio MRI, angio CT, cardiac echo, and so on. Number two would then to review all the data again with a stroke expert, because maybe the stroke expert will look at the same plaque differently that you will, and he will say this is a very bad looking plaque and this will cause stroke, and you don't need to look for other causes. Then, if you still think it's a rare cause, you make a hypothesis. You think this is more like prothrombotic or a rare cardiac cause or a genetic cause, and then you select your next test. You can't do for everybody the whole battery, because then everybody will get crazy, especially the health insurance. So you have to select your next step, and then you check whether the results are positive or negative. And of course, if you still have not found it or you have doubts, you should send the patient to a stroke center. And what does a stroke center do if you send them these patients? Well, they start at the bottom again. They will review all the tests and say, well, could it be this or that? And they'll make a hypothesis. They will add on tests and so on. And here is a checklist of things you can do to look at these rare causes of stroke. Fundoscopy, lumbar puncture, find maybe hidden risk factors like sleep apnea, transesophageal echo, of course, prolonged monitoring to find the atrial fibrillation that you've missed, cancer search, and then extended blood tests for all kinds of diseases that we have mentioned. So to summarize, we have mentioned that you should look for the red flags and then look for specific causes. Of course, it's nice if you're updated on a couple of the rare causes of stroke and you know the clinical or radiological pictures. Again, review the whole basic workup, add a few exams, and then make a hypothesis, and hopefully at the end of the day, you will find the cause and help the patient. Many thanks.